All right, welcome everyone. And on behalf of the Military Liaison Committee of the AAST, I'd like to welcome you to today's webinar. I'm Lieutenant Colonel Timothy Plackett. I'm an Army trauma surgeon currently assigned to the Military-Civilian Partnership at the University of Chicago. Tonight is the second in a series of webinars that'll be focused on common questions about forming, building, and maintaining military-civilian partnerships. We will be expanding upon the topics discussed during the first webinar, as well as entering some new areas. In particular, we'll be focusing on practical aspects such as credentialing, licensing, billing, and deployments. While the majority of the discussion will focus on pre-selected questions, we've opened the chat to allow members of the audience to submit additional questions that we will attempt to answer during this or subsequent sessions. As many of you are aware, the military-civilian partnerships have been around in the U.S. since at least the 1950s, serving as a platform for knowledge exchange and deployment readiness. Military personnel assigned to these civilian institutions provide high-volume, high-acuity trauma care that doesn't exist in most military hospitals, but is critical when deploying and providing combat casualty care. In recognition of the importance of military-civilian partnerships, Congress passed and the President signed the Mission Zero Act into law in 2019. The Mission Zero Act established a grant program within the Department of Health and Human Services to support broader and wider development of military-civilian partnerships with large, high-volume trauma centers. In fiscal year 22, Congress appropriated the first funds for the Mission Zero Act, and 25 trauma centers across the United States were awarded funds. With fiscal year 23, funds are forthcoming as well. With the renewed focus on military-civilian partnerships, the Military Liaison Committee, in cooperation with the Military Health System Strategic Partnership with the American College of Surgeons, felt it was important to host a forum to share experiences and best practices from leaders who have led some of the premier partnerships in cooperation with each of the three services. While we talk about military-civilian partnerships as one entity, each of them is in fact quite different. And that's part of what we hope to highlight tonight. Each of our panelists represents programs that differ in structure, staffing, scope, and service. And we hope this prompts discussion and collaboration moving forward. With that in mind, I'd like to introduce tonight's panelists. Dr. Carl Schulman is a professor of clinical surgery and senior associate dean for research operations at the University of Miami and Ryder Trauma Center. The Ryder Trauma Center holds the distinction of being home to the Army Trauma Training Department. Dr. Fred Starr is the division chief for administration at the John H. Stroger Hospital of Cook County in Chicago, where they are primarily partnered with the U.S. Navy. Dr. Ken Wilson is a U.S. Army Reserve Colonel and the trauma medical director at the University of Chicago, which is primarily partnered with the U.S. Army. And Dr. Randy Woods is a former U.S. Air Force surgeon and currently the chair of the Department of Surgery at Wright State University in Dayton. And they are primarily partnered with the U.S. Air Force. I'd also like to introduce my co-moderator, Dr. Jeremy Cannon. He's a U.S. Air Force Reserve Colonel and professor of surgery at the University of Pennsylvania, where he's also the Trauma Program Medical Director and Section Chief of Trauma. Lastly, I would like to thank the AAST Board of Managers for their generous support of this and other military-associated initiatives. We appreciate the strong relationship and want to acknowledge your leadership and generosity. As a reminder, I'd encourage audience members to submit questions in the chat, and we'll do our best to address them, time permitting. So to start us off, I'd like to ask each of the panelists to provide a brief description of the partnership at their institution. And being an Army man myself, I'd like to start with Dr. Schulman, since his institution is the Army's longest standing partnership.
Thanks for that. Happy to be here, and thanks to the AAST for making this happen. So yes, we've been a Army Trauma Training Center and now detachment since 2001. So a very long-standing collaboration over 20 years. And it's an incredibly unique situation we have because it's really a partnership with two different institutions. So we have a partnership with the University of Miami and a parallel agreement and partnership with the Jackson Memorial Hospital Public Health Trust. And so we actually provide some very unique pre-deployment and sustainment training for the Army's forward resuscitative surgical teams, and have been doing that on a monthly basis. So we rotate about 11 teams through a year for their pre-deployment or sustainment training. It's morphed over the years. Used to be a month long, and then when September 11th happened, we wanted to rotate way more teams through, so it got shortened, and it's gone up and over the years, or gone up and down over the years. Currently, it sits at about 2 weeks. And the first week of the program is a combination of didactic and skills training using simulation, live tissue exercises, and some very focused hands-on clinical care. And then the second week is where the teams come to the trauma center and they take care of patients as a team. So it's a great team building exercise. The FRSTs come together sometimes to work as a team for the first time or the first time in a long time. And it's really a special program. The other unique thing is we have a large permanent cadre of Army personnel, about 15 personnel, if you include the 2 civilians, I think. And that includes 2 trauma surgeons, 1 orthopedic surgeon, 1 ER physician, about 5 nurses, an OR tech, medic, an LPN, and an OR nurse. And they're a permanent cadre with us. And they work alongside us. And I think we're going to get into some of the other questions about that. So I think I'll end there to say that our partnership has really survived the test of time because the 2 institutions, the University of Miami and the Jackson Memorial Hospital Public Health Trust, have been committed over the years to making this work. We've had a lot of legal issues, a lot of administrative issues, but both institutions have been steadfast in their support of this, and that's really what has made it work.
Thank you so much. Dr. Starr, can you talk about the program at Stroger?
Certainly. First of all, I'd like to thank Dr. Plackett and Dr. Cannon for inviting me to talk about what we're doing here at Cook County Hospital, as well as AAST, for allowing us to kind of go back and forth and talk about kind of our experiences and what the other centers have been experiencing as well. I think it's really good to have this kind of back and forth with knowledge, because a lot of this kind of, we're breaking ground. Some of the partnerships I know are very old, 2001 or so. Ours is kind of one of the younger ones. However, we first started our partnership with the Navy back in 2012 with Great Lakes up north, the naval station up there with the FHCC level, where there were a couple of the general surgeons who were stationed there who were interested in getting some trauma experience in between deployments. And they would just volunteer to come on down after we signed an agreement. And they basically took call as fellows and just to gain some trauma experience, as well as just kind of sustain their skills between deployments. That morphed, kind of, that was like the camel's nose under the tent. And that kind of morphed into another partnership with the Navy in 2017, which was the genesis of the HMTT, or the Corpsman Trauma Training Program. That was started, basically that involves training corpsmen prior to deployment with hands-on experience in our hospital. They come and spend the first 2 weeks are didactics up at Great Lakes. And then the remaining 6 weeks of the program, they're with us, actually embedded and actually touching patients. It's hands-on, it's not an observational experience. That program was started in 2017, and that has been replicated in 3 other sites now across the country. From that program, we continue to have talks with the Navy as far as other opportunities we can have as far as training goes. And as of October of 2022, we started embedding an ERSS team with us. So that's a 7-person team that's consisting of a general surgeon, an ER physician, a CRNA, a surgical PA, a respiratory therapist, a ER critical care nurse, as well as a surge tech. That is a group that's with us for 3-year period. The first year being the training portion, where the team trains together. They actually take call in respective areas a lot of time, but then 2 to 5 times per month, they all take call in the same 24-hour period. So they're all working together to work on that team building skill. An additional component to that is there's an embedded cadre of 3 personnel, which consists of a trauma surgeon, as well as a perioperative nurse, and we're still waiting for the administrative assistant to come. That's been promised to us by the Navy, but hasn't been delivered quite yet. So we're still hoping that comes. But that group is here for a 3-year period. They're supposedly not deployable. The ERSS team, which is here there for a year, then they'll be deployed potentially the following year, and then they'll come back in the 3rd year of the cycle as just a sustainment group. So that's kind of basically it. I know we'll talk more about some of the particulars of how we onboarded people and some of the kind of specifics of the program. We'll talk more with some of the follow-up questions.
Thank you so much. And Dr. Woods, can you talk about the program at Wright State?
Yeah, thank you, Dr. Plackett, for the invitation to this this session on military and civilian partnerships. Yeah, in Dayton, we've enjoyed a long relationship, as you said, with the Air Force. For the last 40 years, there's been a joint civilian and military GME, graduate medical education training program in over 7 specialties, one of which is general surgery. So the general surgery residency program at Wright State, we combine both the active duty sponsored residents as well as the civilian residents, and we typically graduate between 7 to 8 chiefs per year. So we've had a relationship with the Air Force for quite some time. With Wright State being a community medical school, we work out of multiple hospital systems in town to include our local military treatment facility at Wright-Patterson Air Force Base. Over the last 10 to 12 years, as part of the military civilian partnership, our local active duty surgeons on base have rotated for 1 week a month on the trauma team at our local level 1 trauma center alongside the Wright State faculty and residents. And then separately, about 8 years ago, we welcomed our first embedded surgeon, and which has recently grown to 2 embedded surgeons on the trauma team at the same level 1. The embedded surgeons are fellowship trained in surgical critical care and trauma, as probably the other embedded folks throughout this conversation. They act as members of the trauma team, whereas the general surgeons on base are brought in and kind of ramped up over the period of time to be active members. The mission is to provide our local MTF general surgeons an opportunity to work on the trauma team in town, assisting in sustaining as well as maintaining skills without assignments to trauma centers outside of our community. Both the local active duty surgeons, general surgeons, as well as the embedded active duty trauma surgeons provide a rich backdrop for our military resident trainees in general surgery, which adds to their preparation for their active duty career in the Air Force. I would say, as you alluded to earlier, you've seen one program in the military civilian partnerships. I think there are other members on base, plastic surgery in particular, who've developed their own rotational opportunities with the other hospital system in town, where they spend 3 or 4 days, probably 2 to 3 days a week at that facility, actually seeing patients, and then the rest of the time on base. So it's developed over time as a rather rich opportunity for the local surgeons to engage with the local community and maybe do a little bit higher case mix and complexity than they would if they just maintain their skills on base.
Awesome. Thank you so much. So at this point, I'm going to turn it over to my co-moderator, Dr. Cannon.
Wonderful. Thanks, Tim, and thanks to all of our participants for taking time out of your busy schedules to join us for this second in our series of MilCiv partnership webinars. I do want to pause for a second. I think Ken Wilson has been able to join us. I see him flashing up every once in a while. Ken, if you're able to connect to audio, we were just going through and giving a high-level overview of each of the MilCiv partnerships, sort of the genesis, some of the history, and then where you are currently.
That's great. Thanks, Jeremy. Can you hear me okay?
Yeah, loud and clear.
All right, great. Sorry, I was actually doing administrative stuff. I guess you can see my eyes darting back and forth. So yeah, we are in the city of Chicago. We are literally having our 5th anniversary to honor our opening on the south side of Chicago 5 years ago. So we are a young trauma center on the south side of Chicago, which is infamous for a lot of things, one of which is penetrating trauma, which obviously makes a great marriage in peacetime for the United States Army, who's going to see these type of injuries. As we opened 5 years ago, we opened the civilian, our MilCiv program 2 years ago, Dr. Plackett being the first person through the doors. And that was then followed by Nick Jasic, who left the program. You still there?
Yep, Ken, we lost you for a second, but I think you're back.
Yeah, it was an incoming call. There's actually a shooting that just took place a while ago, so I'm still feeling calls. So I was saying, we have two surgeons, which have now been followed by a CRNA, an ER doctor, a critical care nurse, and an ER nurse, who are all on board. The way it works for the surgeons, they are fully embedded as full members of the team. They have the same clinical duties, research duties, and academic duties. As a matter of fact, Dr. Plackett, he won't boast about himself, but I will, receive the Golden Apple Award. So the nurses are also part of the team in their various sections. We have the advantage of having two reserve units that are around us, one right here in the state of Illinois, another one in Minneapolis, who have joined us to come train. So we've given them the same paces that we would give our residents and anyone else in the trauma service. And we are now expanding that to include live tissue labs, hopefully by this summer. So again, young program, 5 years, MilSIP 2 years, but we're really proud of it and the progress we've made. Thank you.
Wonderful. Thanks, Ken. I'm glad you're able to hop on. Looking forward to a rich discussion here. Tim has the questions pulled up. Just as a fair warning to our panelists, we won't necessarily go in this order strictly. We'll sort of go with the flow a little bit. We'll be fielding any of the questions that might come up on the chat, and then Tim will have some follow-up questions. So I think with that background and context, as a preamble, question 5 is really important. So I do want to get to that and want to make sure we can address that sort of practical challenge, but we'll lead off in the order that Tim has outlined here. So in your MilSIP partnership, how are the military partners credentialed? Specifically, is it we heard in one instance, they started out with fellow credentials. Are some of the team members brought in as a fellow? Are they all brought in as faculty? How have you handled that challenge? And just to mix up the order a little bit, I'll start with Fred, if you don't mind. Dr. Starr.
Sure. So part of our team, the ones that are actually credentialed would be our general surgeon, our ER physician, as well as our APP. So we have a PA and a CRNA. So the general surgeon is voluntarily credentialed as a voluntary attending. So they have the full privileges of any of the other attendings. However, because the general surgeon has not done a trauma fellowship and they are not boarded in critical care, we always will stay in-house with them. So as the year has progressed, we step back more and more and give them increased autonomy to basically run the show. The ER attending is also credentialed as a voluntary attending, and a lot of times it's taking shifts in the ER. A lot of you probably don't realize, but the setup at Cook County is a little unusual in that the ER is separate from the trauma department. So we have our own trauma, basically a trauma ER with 14 beds plus a shock room, which is across the hall from the regular ED. So sometimes the ER physician will be working shifts over in the regular ER and doing regular ER stuff. And then several times a month, they'll be taking call with the team over in the trauma department and taking call as basically the attending who runs the resuscitation in the trauma area. But when they are credentialed as full-fledged attendings, but with voluntary status.
Wonderful. Ken, how have you handled the credentialing question at University of Chicago?
So, keep it simple, because the University of Chicago didn't really know what to do with us until we finally got there. So we just mirrored what everyone else has done as far as the surgeons are concerned. Get your Illinois license, allow enough administrative red tape for that. Then it's the same onboarding as any clinical associate or assistant professor. But the surgeons coming on board and the ER doc coming on board are all clinical associates through the medical school. The CRNAs, I can't tell you 100% how that's done, but I would imagine that it's the same way that all CRNAs come in. There's, I guess, in summary, there is no division between us. They just kind of come on board like anyone else coming to the University of Chicago comes in to our system.
Very good. And Randy, what about you?
Yeah, similarly, the local MTF general surgeons and the embedded fellowship trained trauma surgeons are both credentialed at the trauma center as independent practitioners. But the embedded trauma surgeon really does come on board as one of the members of the trauma team, depending on their background and all, but fairly quickly spun up. The local general surgeons, there's usually about a 4 to 6 month period of time after they arrive in town before they actually even start coming over to the trauma center. And then after that, we kind of slowly work them on the team. They really pick up with the EGS, the emergency general surgery. We do both EGS and trauma on the acute care surgery service. So they really run with the EGS right away. And then the trauma has been mentioned previously. We're there and we kind of slowly back off depending on their comfort level and and quite honestly, their level of interest.
Fantastic. And to wrap it up for this first question, Fred, how about at Miami? How are you guys dealing with credentials? Maybe a different situation since you got a sort of a just-in-time model.
Yeah, so Carl at Miami. Yeah, so in Miami, we have 2 different types of service members, right? So we have our permanent cadre of the training center staff. And so the surgeons, just like everybody else has mentioned, they come in, they get fully credentialed. Well, I should say the physicians, all of the physicians and surgeons come in, they get fully credentialed, and they are voluntary faculty, and they have, same privilege as anybody else. And they work both when a training team is here and when they're not here to take shifts in their respective disciplines and take trauma call with us, et cetera. The actual rest of the permanent cadre, the nurses and the techs and so forth, they're also fully credentialed by the hospital, and they also, practice alongside our regular staff when a team is not here and when a team is not here. So they're fully integrated, but everybody gets credentialed just as any other sort of employee would at our institution. We also, of course, have the rotating FRST members. They come in as trainees or fellows. And they're credentialed, but they're credentialed as trainees or fellows. But with that, they don't really have any restrictions on patient care. They take care of trauma patients as a team from the moment they hit the door all the way through their initial care, resuscitation, even the OR, under the supervision of either the trauma training department staff personnel or our own trauma center personnel. And similar to Fred, we have a separate freestanding trauma center, so it's not intermixed with the regular ER.
Carl,
I
thank you.
think
I'm sorry
this
about
is
that.
a similar theme to what we heard during the last webinar, where if it's, a fellowship trained trauma surgeon, it's very easy or easier to credential them. Whereas when it's a general surgeon, looking at more of a trainee model seems to be the popular approach that people use.
So just as a note to that, actually, we did have, so over the years, the commander of the Army Trauma Training Center and now Army Trauma Training Detachment has changed over the years. It changes every 3 to 5 years. And we had at least one circumstance in the past where the surgeon commander was not trauma or critical care trained or boarded and in critical care. And he was not able to take call because it didn't meet our, level 1 requirements to be on our roster. So while he could do general surgery, he couldn't do actual trauma call or critical care with us. So but most of the other commanders and other rotating physicians in the last, say, 8 or 10 years have all had those credentials, and we haven't had a problem.
Great. Tim, over to you for any follow-up.
Yeah, did any of you notice any difficulty with trying to get the CRNAs or the nurses, not necessarily credentialed, but brought in? They seem to be an area that sometimes from the soldier end, you hear about potential friction initially when setting these up.
I can take a stab at that. So we have a CRNA and we also have a PA, and then we have a ER critical care nurse. So all of our naval embedded personnel are all additional staffing for us. So they're not displacing any of the nurses that are actually already scheduled there's various union agreements, et cetera, which kind of complicate labor issues, but all of the staffing is additional. So if they actually love having the CRNA up in the OR right now, that kind of helps their scheduling a little bit. But there's been no friction. In fact, they probably use them more than maybe they should. They're trying to use them as much as they can in order to relieve some of the regular employed CRNAs. The PA, again, we don't have PAs on our service, so there's no friction with that. That's actually, it's been a great, actually, eye opener for us to see what PAs can do for a trauma service.
Yeah, I would just say we're not currently having any of those issues. So we've been, a program for over 20 years. And we haven't really, in the past, I don't remember any friction other than, the occasional interpersonal thing. But in terms of getting them on board, getting them credentialed to the hospital, it's a big county public hospital. So that system is pretty robust. And we haven't really had any of the problems mentioned.
We don't have a lot of the nurses, whether it be in the ICU or the floor, coming over embedded with the team quite yet. There's discussions about that, and I think there's new leadership at the local MTF that might have that as an interest going forward. The advanced practitioners, PAs in particular, are credentialed through the normal credentialing process and haven't had much of a problem, I don't think.
Tim, do you want to take this chat question or move on to number 2?
So the chat question was asking, are any of your institutions also onboarding medics? And I would add to that, LPNs. We certainly use them in the military, but the way the military uses, say, an LPN or a medic, or what we want them to be able to do on the battlefield, is very different than what they often could do in a hospital or in a civilian environment. So what's your experience been with those type of personnel, if you have them there?
All right, I think Fred, you're using, you have that HMTT program that's strictly medics, right?
Yeah, we have the corpsmen come in for 6 weeks, and basically they are there in the resuscitation area. They do help with all the resuscitations. They help strip the patients down. Really, the idea is for them to get experience seeing. We have a lot of penetrating trauma as well, just like you do down the street in South Chicago. So just get that experience with the initial evaluation of the patients, but they don't do any pre-hospital work with us. We don't have a helicopter. We don't have them go out with the Chicago Fire Department at this point. That's something we're working on potentially in the future, but right now their 6-week mission is really to be in our resuscitation area, as well as they go a couple other areas in the hospital. Just basically to help out as extra hands, lifting, placing IVs, doing things that the corpsmen are capable of doing in the ICU setting, as well as they rotate through our ER, as well as our burn unit.
So just for the audience, in the Navy, they call medics by a different name, as they do, many of their ranks and whatnot. So the Navy medic is a corpsman. So great. Any other sites have medics on your teams?
We do have a medic on our team, aside from the rotators, obviously, that come in and handle the resuscitations as part of their FRST activities. And they, similar to what Fred described, they assist in the resus area, like an LPN, and also does some of the community outreach with the trauma center with our outreach coordinator for the trauma center.
let me say, unlike Fred, we don't have medics, but we certainly, as military folks, recognize that as surgeons, we can't do our job without the medics. So that has been a push in our institution. LPNs in our institution are only allowed to be in the clinics, which doesn't help anyone because it might as well just reproduce the MTF experience. So what we have decided to do as we expand this is to treat the LPNs and anybody who's of medic status to the ED, which is pretty dynamic. A lot of resuscitations are text downstairs would be the equivalent, and they are very essential to what we do. We do have a helicopter that flies out to Indiana, where they go out. Obviously, we have rural medicine. We have Gary, Indiana has the Knife and Gun Club. We also have a dormitory that we've set aside that's on the campus. So obviously, you don't want people walking back and forth at night, so we can be on the campus at night. So we haven't done it, but we recognize the importance of it, and I think all those who don't have medics should, think of a creative way to make sure they get them onto their team. Thank you.
A really great point, Ken. Tim, if you're okay, I will move on to the next question.
Sure.
All right, so licensing. What are the licensing requirements that our military partners in these MCPs need to meet? And are there any additional institutional requirements that are piled on top? So Ken had mentioned the Illinois licensing. I don't think we're at a place where we, in any of the sites that I'm aware of, where we have, sort of a federal licensing agreement, but that would ultimately be an ideal state. But how are you dealing at your MilSIP partnership sites with licensing, and do you have extra requirements? Randy, why don't we lead off with you?
Yeah, sure. Thanks. We do require them to get an Ohio license. And as you said, that usually is something that they don't come with. I know it's later on down in the discussion, but we cover all those costs with the Ohio license as well as the DEA. And then it just depends on whether they're the embedded trauma trained surgeons or not. We kind of talked a little bit about the general surgeons, local general surgeons, bringing them on kind of in a graded fashion, whereas the trauma trained embedded surgeons, Air Force surgeons are really incorporated into the team as one additional member of the team. Very
good, thank you. Dr. Schulman, how are you guys doing it there in Miami?
Yeah, similar. So all our, our permanent staff, the surgeons are required to get state licensing, which of course takes a while. And the other clinical staff, the nurses and techs and so forth, are required to get whatever commensurate licensing they have. In terms of, and so the rotators don't have to get any special licensing. They come in as trainees, and we have reciprocity as long as they have licensed in their own specialty field. They don't have to get anything special for Florida. In terms of paying for that, on the university side, we pay for the licensing for the physicians, but the hospital side's been a little bit more difficult. The hospital doesn't really pay for all its staff licenses. However, recently, the trauma chief and the director of the ATTD have worked closely, and the hospital is now helping to facilitate and pay for the requirements that they need to keep up their license, their CEUs and the other courses they need to take to maintain licensing, because they do provide that for their normal staff. They run courses, and the courses are free. So the Army staff are now being able to avail themselves of that.
Have you noticed any, say, delays in startup due to licensing? Has that become, such a protracted process?
So I'll say always, when you're dealing with the state or any licensing agency. I mean, we've gotten good at it over the years. Some go smoother than others, but yes, it can be a hiccup to them starting their clinical care with us.
And good to build in that buffer. So really, as soon as you get the notice that someone's coming, start the wheels in motion. Ken, how have you guys done? You mentioned the Illinois license. Was that a challenge?
Like anything, when you deal with the government that works, Monday through Friday and gets Columbus Day off, there's always those delays, but we try to get them, into the system as soon as we know that they're coming. Usually by the time they arrive, that license is in hand. It's funny you mentioned the fees, and then I have to ask Tim. Hopefully, he didn't come out any pocket with any fees, because if we got to fix that. But beyond that, we pretty much just follow the same script that has been mentioned.
All right, Fred.
So it sounds like we're a little unusual. I was very pleasantly surprised that Cook County decided to honor Title 10 of the US Code. So we actually don't require any of our embedded people to get any state-specific license. We will honor whatever license they have. So that was a real pleasant surprise. All we do require is that any of our embedded people have whatever our requirements would be for any other employee within the hospital system. So they all need ALS, BLS, things like that, which if they don't have, because we require for any of our people, that we will pay for that. But pretty much everybody who comes through here already has BLS and ALS. Other things that we require, so the licensing is actually super easy for us. The other things that kind of are a little bit actually pretty easy also is drug tests. We'll take the military's drug tests, their background checks. We will honor all the background checks as well. So it's actually fairly easy onboarding here, surprisingly.
That's great to hear. I'm really intrigued by the Title 10 approach. That's fantastic. Was there a protracted legal discussion or any back and forth that you could share with us?
When we brought it up with our legal team initially, I was very hesitant to bring it up. I was pretty nervous, and they immediately said, "Yep, that'll be fine. We'll accept that." So that's true for our the HMTT program. So part of the HMTT program is we have the corpsmen coming through in classes. We also have 6 preceptors who are RNs or IDCs, and they don't need to get a license here. They will honor whatever license they're coming in with. So that was kind of the groundbreaker back in 2017. And then when we started doing the ERSS embedded program last October, they just followed through with the same language. And legal, surprisingly, again, has not balked at that.
Oh, that's great to hear. Tim, over to you.
Yeah, Dr. Starr, this has been a frequent point of discussion for those of us in the partnerships. And I think, this is one of the great things about this webinar is hearing best practices. And, it sounds like Cook County nailed it out of the park on this one. And we probably all need to reach out to you and figure out how exactly, how your legal team came to agree with you on it, and see, can this be replicated potentially at other centers? Because this has been potential cost for the service member, and has been something that, like everyone has said, leads to potential delays in the onboarding process. So I look forward to hopefully hearing more from from you and from Cook County on how this went, so that we can all learn from this going forward. But in the interest of time, I'll say, why don't we kind of move on to our next question on here, which some of you spoke to, which is how do you address some of the potential costs that could be incurred in the partnership? The one that comes to mind is, all of you work in busy cities that don't usually offer parking for free for their physicians. And I'm sure there's other small things that come up along the way. And so are you able to help offset those? What kind of things have you seen? What is allowed and what is not allowed?
Ken, you want to take a crack at that?
No, because we're failing in the consistency with that. Yeah, so yeah, really, you did. Tim and Nick both came in, and so we have two things. We have the BESD, which is the Biological Science Division, which is the medical school, and they came in, and without even knowing how it happened, badges, parking access happened, And then on the hospital side, the nurses came in and the CRNAs somehow were able to get parking. But I got 2 nurses that I've taken this always to the provost's office to say, hey, look, if you want the program, you know, you got to recognize what we need for them to be equal partners there are everywhere else. It shouldn't have to go that high, but it's gone that high. You know, Tim is going to kind of take over this portion for me as being the the liaison. So Tim, I don't know if you have anything clever that you can come up with, but you know, I've been trying.
Randy, how's parking for your team there in Ohio?
It's not been a problem. And to date, we've mainly focused on partnering or bringing on board the physicians. And as I mentioned before, they get credentialed as independent practitioners. We just may not let them start immediately independently, depending on their background, whether they're fellowship trained or not. I imagine if we're able to grow the program to respiratory therapists and nursing and stuff, we may have more problems or difficulties with parking. So far, they get the same parking ability as the other credentialed medical providers in the institution.
Dr. Schulman, with your model, it seems like maybe you've had enough time to figure out designated parking, maybe?
Yes, so I could start by saying that everybody pays for parking at UM-Jackson. So I pay for parking, all the staff pays for parking, so everybody pays for parking. And so the military folks also pay for parking, although they can get our rates. However, like you said, there is difficulty getting spots in parking lots and so forth. So that has happened. So they get spots in our parking garages as if they're, they are one of us. So, but everybody pays, but parking is sort of, a spot is guaranteed, but it comes with a price.
And the other costs of doing business, licensing and the other training requirements, are you rolling those in to your budget, or is that something that you're handling in a different way?
So licenses, yeah. So we pay for again, as I mentioned earlier, we pay for the licenses for the physicians and the hospital. What we've done is, if it's something that we would normally pay for one of our own faculty, we pay for it for our Army colleagues faculty. And on the hospital side, we're working on a similar model. So if it's something that they would normally cover for any of their staff, whether that's credentialing or licensing or maintaining their requirements, we've been recently a little bit better at getting the hospital to pay for those for our Army cadre.
Now, before I really got involved in these partnerships, I didn't really appreciate the different sort of chains of command and the budgetary alignment of these different groups. And so, yeah, as you heard earlier, Ken having to go up to the provost for one group, whereas the other, it was no problem. It's really a fascinating phenomenon. Fred, how are you handling these sort of miscellaneous expenses?
Yeah, so parking, I think just like Carl said, we pay for parking. All the physicians here pay for parking. The Navy has to pay for parking. There are spots for them, though. We do have a garage, indoor and outdoor garage. So it's no problem getting a parking spot, but they just have to pay for parking. There actually is fairly good public transportation here. So some of our team actually will take public transportation. And then there is some way of getting that reimbursed by the military, I have heard through the grapevine. Other little expenses, one thing that did come up that we've solved was, do voluntary attendings have to pay medical staff dues? That was something they potentially wanted them to pay. That's written into our MOU that they do not have to pay for medical staff dues. Other expenses, again, I think Carl mentioned it. If the hospital pays for it for their other employees, the hospital will pay for it for the military when they're here. Anything outside of that, though, extra courses, travel to meetings, things like that, that all gets billed to the military.
So one of the questions in the chat was dovetailing kind of off of this and asking for those of you that applied for and received Mission Zero Act funding, while the proverbial check may still be in the mail, have you earmarked any of that to help offset, how you're supporting the service members. So, some of these things you're paying for, are you planning on using the Mission Zero Act to cover that, or is that earmarked for other projects?
I can maybe start. My mic is still open. So we had that in our budget that we submitted. And then the budgets were all summarily cut. So we are using still internal resources to pay for those kinds of things. And we're going to use the Mission Zero money for more data tracking and ability to have some data management and personnel. But the other thing I should mention that was mentioned to me by the Army staff and the physicians here is the other cost that we didn't talk about was the cost of living in an urban city with a much higher cost of living than they would normally have in on a military installation. And so those costs are very hard to offset. I know there's an adjustment based on where you live, but if you take, for example, the Miami market right now, forget about our military partners, our regular staff has a real difficulty maintaining their cost of living with the rising cost of particularly housing and other things in Miami. And so that's sort of an unanswered question.
Anybody else have experience with the Mission Zero Act and how they were potentially using the funding?
We're applying for Mission Zero funds this year, so we haven't had any to spend yet.
Well, we applied for it and we got it, but I think there was not a lot of direction on how to use it. So since we're talking about a military civilian training partnership for the first round, hopefully there'll be future rounds. We put that earmarked for training. Obviously those things cost. Some of these high fidelity mannequins, some of the pig labs, they cost. But now that we're probably going to have those things up and running, the previous statement about metrics, how many axillary artery ranges have you done, how many shunts have you done. We thought about financing that person, but it was mentioned about the cost. It's very expensive within the city of Chicago. So by the time you take the money that's available, you're kind of almost insulting someone with the money as to what would happen. So hopefully with the increased funding, we can now just shuttle all that money into having one individual who just basically does metrics and maybe some interoperability type of projects between the other military civilian projects. So that's what we hope to do in the future.
That's great. Thanks, Ken, for that. Those insights. Really interesting to use the money for training as it was designed. That's great. Tim, if you don't mind, I really want to get to this deployment question. I think it's so important and really an interesting challenge. So how have your MilCiv partnerships handled deployments? Carl, if you don't mind, you've got a slightly different model. Could you lead off with, say, if your permanent cadre were to get orders, that would probably throw a pretty big wrinkle, and I suspect the Army may not want to do that to you, but has that come up, or do you have a contingency plan for dealing with that?
So it absolutely comes up. And I'd say our answer to the problem has been very simple, and it's volume. So we have a very large permanent trauma faculty at our institution. We have about 20 different people that take trauma critical care. We cover a bunch of ICUs. We have the largest fellowship training program in the country with 7 critical care fellows and 7 trauma fellows, so 14 fellows a year. So we are able to absorb our surgeons leaving on deployment, and they do get deployed, and they have been deployed. The Army does not tend to deploy the rest of the ATTD staff, so they would have to absorb that. The hospital really can do without some of the other staff, and we as a trauma group, just again because of our sheer size, are able to absorb the shifts that might be left open for 3 to 6 months or however long the deployment is for one of our physician colleagues.
Very good. Thank you, Carl. Really appreciate it. Fred, has that come up in the course of your partnership?
We have not had that come up yet. The HMPT program, which was started in 2017, they actually are here for 6 weeks prior to deployment or getting at least operational orders, but no one has ever been pulled mid-course. The ERSS team that has just been embedded in since October, the plan is, so there's the rotating ERSS team that's here for the first year of training. The second year is a planned deployment. The third year is coming back for sustainment. But then, so that group potentially could be deployed, but again, we have enough redundancy in our own staff that these are just additional people, so that would not impact our functioning. The embedded cadre that we have, which is made up of a trauma-trained trauma surgeon, as well as a perioperative nurse, they are technically not deployable, but obviously things can happen and they might get deployed. Again, they're additional staff, so we have enough redundancy built into our system that we could function without them.
Very good. Dr. Woods.
Yeah, one of our embedded trauma surgeons is deployed right now, and I'd say to some degree, although not nearly as big as University of Miami, we do absorb that loss. We got the second embedded surgeon a year ago with the understanding that when one goes, we'll still have one around, but then we obviously quickly used 2 to almost their full FTE. So it usually is the rest of the team kind of absorbs the loss. The general surgeons on base, there may be times where if there's one deployed and one out for post-deployment or maternity, paternity leave, whatever it might end up being, that will skip a month or 2 where they rotate on the trauma team. So that kind of flexes a little bit depending on how many folks are deployed out of the base MTF.
For some of our special ops partnership sites, I've heard that they sort of count on sort of a 2-for-1 model where they double up on the number of assignments, anticipating that one or the other will be out of pocket quite frequently. Dr. Wilson, over to you.
So we just had this scenario where I think, Jeremy, last time I spoke to you, I was in Honduras, and at that time Tim was in Iraq and Nick was in Doha. So you had 3 surgeons out at the same time. So we try to make sure the best that we can, especially on the reserve side, since I can control my schedule a little better, not to be gone during the summer fighting season in Chicago. So we kind of pride ourselves on more touches, more opportunities to operate. So at least I've tricked my staff into believing that it's a good thing when we're short, and they take that mantle and run with it. So it has happened. About 2 weeks ago with the situation in Sudan, the entire FRSD was about to get ready to go. And then they were told to stand down. So in anticipation, we talked to all the various sections and let them know. And they staffed and beef up pretty quickly. Fortunately, it didn't happen, but we've had deployments, we anticipated deployments, and we're ready for it.
Very good. Thank you for that. Tim, back to you.
Yeah, so my follow-up is really asking about after the deployment, because 15, 20 years ago, people went on deployments and they did hundreds, if not thousands of cases, and they probably came back a more competent surgeon than when they left. And now we have, the reverse. My own deployment, I did 1 case over 3 months. And so for those of you that have had surgeons deploy from your program and then, return, how do you deal with that variability of, I don't know how much experience they had on the deployment, and then reintegrate them, back into your program?
I guess I'll start. Honestly, I don't know that we did a lot with our most recent deployment last year when he came back, and he was gone for a solid 6 to, it was a little bit more due to the stuff that normally happens with deployments. But it really was, there was a pretty quick ramp up, I guess I'd say. There wasn't much of a delay in getting him at least back into the fold. Now, obviously, there's always senior surgeons around that are willing to help out at any time, like at all of our institutions. So I don't know if that was an uptick during that period of time or not, but there wasn't much of a delay, I'd say. Right or wrong.
Did you use a formal, process, like put them on a 50 and have someone directly observing, or was it, your partners are available, low threshold to give us a call?
It was very informal. Your partners are available to have a low threshold to give us a call. Yeah.
That's really a great insight. Appreciate that comment. Tim, I'll defer to you. Do you want to cover billing or tackle some of these questions in the chat?
Sure. Why don't we ask about the billing, and for those of you that have questions that were unanswered, we do have another session next month, and we'll try to get those incorporated into that for you. So the billing question really is, are you able to bill, and how are you billing for the services from your military surgeon?
So Ken, you want to lead off?
Yeah, sure. The same magical office that my billing goes to is the same place that our active duty surgeon's billing go to. There's no separation between us.
And are you able to pull KSA numbers through that process?
I believe yes, because I believe Tim has actually submitted a paper to you for publications around it.
It's awesome. Randy, how are you guys dealing with the billing situation?
Similar. The Wright State physician practice plan, part of the reason why we need a state license, at least to date, was they get credentialed with all the insurers. So it's a little bit of cost out of the corporation, but on the other hand, we bill through the practice plan, trying to be aware of, on the back end, the TRICARE patients, as there are some in the Dayton area. When I reached out to the billers, they'll either they won't bill, or they'll try to see if there was someone else, at least that was in the room or at least partly available, that they may bill under them. But
has that been a significant impact for you? That was that came up.
Yeah, I don't think it has been, but that was just a conversation that I began with the billers with our practice plan last week when I saw the questions here again. But to date, they didn't seem like it was a big problem for them or for us.
Fred, how are you guys handling billing?
So all of the physicians in the county system are salaried, so we're not RVU based at this point. So it's written into the MOU that all services provided will be billed by Cook County Hospital, and all funds will go to Cook County Hospital. The only exception in there, I think, is that you alluded to, was the TRICARE issue, where if we do have one of our Navy surgeons on call, they can't bill for the TRICARE patient. We have, I can't even remember the last TRICARE patient we had that came through Cook County. So it hasn't really been an issue for us.
Carl, do you have TRICARE down in Miami as a challenge?
Very rare, like Fred says. We did have one of the Army parachute teams have an accident. One of our military trauma surgeons was on call, so that initial billing, but everything but TRICARE. I will say that we dealt with this about 15 years ago, and it was a lot of discussion with the military lawyers and the university lawyers, and other people got involved, because initially they were saying they couldn't bill for Medicare, Medicaid, and we went through a couple of years of making sure everybody was okay, and finally they said, yes, you can do everything but TRICARE. And so I'm glad to see that that's not been an issue for anybody else.
Yeah, you blazed the trail for the rest of us. Thank you.
Yeah, and I think this takes us just about to the end of the hour. So I'd like to thank Dr. Cannon for moderating with me, and I'd like to thank all the panelists for joining us today. You gentlemen all have a wealth of experience. Many of you have been publishing on your institution's experience and sharing that, and I know that's very helpful, when you're setting up a new site, to see what someone else has done, so you're not reinventing the wheel, and you're learning from those lessons. So I thank you all for that.